Good evening, everyone. Welcome. It's great to have you all here this evening. I'm Kendra Clayton. I'm the president of the Graduate Theological Foundation. And on behalf of the entire administrative staff, I'd like to welcome you all here today. And I'd like to ask the administrative staff of the GTF to please stand, sort of identify yourselves. Just, we have Amy, we have Russell. Thank you very much. For our graduating students, I'd really like to encourage you to introduce yourselves to us, if you haven't already, during the reception that will follow the Runcie lecture. It's always very nice to be able to put a face with an email, with the phone calls. That we've all worked with you, many of you, many times, and so it's nice to make that personal connection. So please do introduce yourselves to us. We have many faculty members with us this evening, and I'm very grateful for all of you who were able to travel here to join us. Can I ask that all the faculty please stand at this moment? An educational institution is only as good as its faculty, and we're fortunate that the breadth and depth of knowledge and expertise represented by our faculty is immense. So thank you all for what you do. Finally, some housekeeping. I'd like to remind everyone of the schedule of events for tomorrow. All graduates need to report to the Century Center's Discovery Ballroom tomorrow morning at 9. We'll have a graduation walkthrough at that time. It's very important that you're there. The graduation ceremony begins tomorrow at 10:30. Faculty and honored guests can join us at 10 in order to line up for the procession. Immediately following the graduation ceremony itself will be a luncheon that you're all very welcome to attend. We hope that you do. And finally, in culmination, tomorrow from 1:30 to 2:30, we'll be having an open house at the Dodge House, our administrative offices in Mishawaka. Some of you have never visited the administrative offices. That's where the phone calls come from and the emails originate. And you're all very welcome to join us, take pictures, tour the facility. We'd love to have you if your travel plans allow. So, shortly, I'll be handing the microphone over to the Reverend Canon Dr. Robin Gibbons, who will be introducing our Lord Robert Runcie Convocation Lecturer this evening. Dr. Gibbons is a Fellow of the GTF, Dean of Studies of Foundation House, Oxford, and the Alexander Schmemann Professor of Eastern Christianity. Dr. Gibbons is Director of Studies in Theology and Religious Studies at the University of Oxford, and beginning in September, he will be named a Fellow of the Center for Christianity and Culture at Regent's Park College, Oxford. Dr. Gibbons, along with a colleague, will be developing a new research arm of the center entitled Religion, Freedom, and Diversity in the Public Space. He was appointed ecumenical canon at the Cathedral College of All Saints in the Diocese of Edmonton, Canada. The appointment was made in recognition of Dr. Gibbons' broad experience in theological education and outreach, including his work as an Eastern Rite Catholic priest with other churches. The Reverend Canon Dr. Robin Gibbons.
Very embarrassing as I've got to introduce a very eminent guest, so it sounds as though I've got all the things in front of me. It's great delight to be able to welcome you again, but also just to remind you of another housekeeping that may have slipped by. I think many churches and community places now just suggest that you switch off your mobile phones and then put money in the collection. But I'm just saying switch off mobile phones just so that we can have an uninterrupted and relaxed time. I'm going to introduce in a moment our very distinguished Lord Runcie Convocation Lecturer here, Reverend Dr. Douglas Ronsheim. And you've got a lot of stuff about him in the little leaflet that's been given to you, but I'm just going to draw attention to a few of them, going from the bottom up, because I know you'll read the first paragraph and then forget. So we're going to just remind you, first of all, we're all in ministry, we're all participating in pastoral ministry in some way, and so what he's going to talk about is of great effect and very germane to what we all do. But he himself is a Presbyterian minister. I think when he was chatting earlier on, he said in a particular way. I'll leave him to explain what he means by that. But he's also, as you will know, a licensed marriage and family therapist, a fellow of the AAPC, clinical member and approved supervisor of the American Association for Marriage and Family Therapy. He's had a very tight, good, deep and broad career because he's had faculty appointments, as you can see, in various areas at the University of Pittsburgh, in the Western Psychiatric Institute and Clinic, in the University of Pittsburgh Medical School, and in Pittsburgh Theological Seminary. But he's been instrumental, as this tightly says, in developing collaborative models of care and creative models of education for training health-related professionals and community residents. But now, after 17 years, first of all, as the executive director of the Pittsburgh Pastoral Institute, he's now involved as the executive director of the American Association of Pastoral Counselors. The mission, as it tells you, is to provide training, education, and clinical collaborative community-based services to enhance the well-being of individuals, families, and communities. I can't think of anything that I'm more interested in. When I saw that up there, I'd been grabbed by it, and so recalculating pastoral counselling from past, present to future, I am sure will be a wonderful experience for us all. He's going to give us his insight, his knowledge, his experience, and then he's going to be thanked, and then we're going to open out the floor for a few questions until 8 o'clock, at which point I will boot you all out to continue the discussion and friendship in the centre out there where there's food to eat. But I'd like to welcome on your behalf very strongly the Reverend Dr. Douglas Ronsheim.
Good evening. And if we get booted out prematurely, we can continue the conversation out there. I'm going to put this down because with my height, it just might knock me in my forehead. You know, it's with a great sense of gratitude that I'm before you this evening. And on behalf of the American Association of Pastoral Counselors, I want to thank all of you who are related in whatever capacity to the Graduate Theological Foundation for your expansive model of education that provides this on a worldwide scale. That is very, very unique in my feeling. And you also encompass the field of pastoral care and pastoral counseling as well. To the students who are graduating tomorrow, can I have a show of hands of students who are here? I congratulate you on your completion of your academic work and for the continuation of your service to others. To faculty and administrators, I thank you for your desire to instill knowledge and inquisitiveness in students and your willingness to also remain learners at the same time. I've spoken to some of you who said you are still learners this afternoon. And to family and friends who are here, for your support and encouragement to those who juggle far too many things while they are in graduate studies. I'm not a stranger to the Graduate Theological Foundation. Prior to taking my present position in 2003, and I will do my best to try to capture all of you in my sight as I talk. So before I took this job, I have colleagues in AAPC, and John Morgan today reminded me that there are probably 50 to 60 AAPC members who have got their graduate degrees from GTF, many of them in the PsyD program, and many of those colleagues are in leadership positions in AAPC. So you helped to form those, and I appreciate that. Several years ago, my son Aaron, time flies, in 2003, my son matriculated to being a student at the University of Notre Dame. And when I took this job, this became a good excuse for John and me to actually meet with one another over several years, and we would meet when the weather was relatively nice outside the bookstore of the Notre Dame campus for coffee and for conversation and the sharing of ideas. So I'm intrigued not only where these conversations go this evening, but perhaps after tonight as well. Now, I was invited to be with you last fall by John, and he wrote me a letter, and in it he said, "The topic we wish you would consider if you accept the invitation is something dealing with the history, present state of pastoral counseling for ministry professions and where you anticipate the field moving over the next decade." I'm sure if that were my idea for a thesis to you, John, you would say it needs to be shortened and more specific. And I'll try to do that this evening. I will spend more time talking about the future of this field than the past and the present, but we know that we can't get to there unless we've started over here. I'm also aware that many of you helped to build the foundational building blocks in this field. And I thank you for being here because you have helped form this field and this profession of pastoral counseling. So we all know that all of these aspects are connected as we move toward and forward, recalculating our view of our perspective and our direction. So let's begin to envision the future together. Just a month ago, the American Association of Pastoral Counselors celebrated its 50th anniversary where it was founded in St. Louis. So we are kind of a younger cousin to the Graduate Theological Foundation since you have celebrated 52 years of service. At this event, the leadership in AAPC shared with the membership in various ways where we are in a sustainability and strategic alliance initiative. And those two things go together because we can't sustain one another in our family relationships and our community relationships unless we have some type of strategic alliances that we have to work together towards a common goal. So I trust that possible conversations will continue this evening and perhaps even tomorrow after the graduation ceremonies. And so if you have an idea or a good perspective you would like to share with me, just say, let's recalculate. And you know, I left my garment at home and I was going to use it as a stage prop, but you all have heard that wonderful voice saying, recalculating. 6 weeks ago, I was a presenter and also a participant at an online conference sponsored by the Oates Institute in St. Louis. And it was on the future of spiritual care. So this theme is in the air, I think. Yesterday, I crossed this bridge leaving Pittsburgh. I live in Pittsburgh and I work in Washington, D.C., and it's easier to do that than living within the greater Washington, D.C. area. Pittsburgh is known as a city of bridges. It has ostensibly 499 bridges within its city limits. The qualification for a bridge in Pittsburgh is it has piers and it stands on something. So we have very small bridges, but also very big ones like you see before you. The point for me is not so much that of what involves the definition of a construction of a bridge, but one's willingness to cross it. And given the diversity in many ways, geographically, culturally, ethnically, religious backgrounds and traditions and so forth that makes up the Graduate Theological Foundation, you are definitely a community of bridge crossers. So we'll bring you along and make you citizens of Pittsburgh. What I want us to do as I think about past, present, and future is to think about looking at the same picture from a different perspective. In the founding days of AAPC, the perspective was primarily on the identity of the pastoral counselor. One had to be clear about him or herself before they began to be involved in caring for others. Another aspect of the early days of the American Association of Pastoral Counselors in the field of pastoral counseling was to gain legitimacy in the eyes of one's faith community and also one's culture. And some theological frames back then assumed that knowing who you are was the foundation for all the rest that one does. It was also a time when psychology was rising to its fruition and almost became a civil religion. As the field focused on the identity of the pastoral counselor, it also did that because after the Second World War and into the 50s and 60s, a lot of people had lost hope in institutions. And so what can we put hope into but ourselves? And so in the early days of pastoral care and counseling, they wanted to be legitimate participants in their faith communities, their hospitals, and their local communities. A second perspective, more of the present, of the past maybe 20 years. Pastoral counseling continued to strive around the issue of legitimization. It was recognized about 10 years by the Substance Abuse Mental Health Services Administration of the federal government of the United States as one of 7 mental health disciplines. Licensure for individual practitioners was granted in 6 states where one could be licensed as a pastoral counselor. And in the remaining states today, pastoral counselors mostly are licensed in those states, but as something else. Marriage and family therapists, licensed professional counselors, psychologists, and so forth. Now, what pastoral counseling posited at its beginning, the importance of attending to spiritual variables in people's lives, basing practices of counseling that are congruent with one's faith traditions, is now a fabric of counseling and care and mental health disciplines in the United States, and I think in other places of the world. An example of this is the Family Therapy magazine. This is the magazine of the American Association of Marriage and Family Therapists. Its January and February issue is entitled Spirituality and Faith. You're not able to read the small print below, but the first one on page 20 relates to therapy with Muslim families. The second article relates to therapy with devout Christians. And the third article referenced has to do West meets East, of how Eastern traditions are now complementing Western traditions, not only in the behavioral health sciences, but in medicine as well. I'll be glad to send my PowerPoint presentation, John, so you can send it on. Unfortunately, I'm sorry about the size of this. But this is a slide that a conference held 3 weeks ago at the Center for Spirituality, Psychology, and Health at Duke University. Some of you know of Harold Koenig's work, and what he presented was research protocol for a grant from the Templeton Foundation. And he presented 4 models of care that specifically relate to cognitive behavioral therapy related to faith traditions. And the protocols that he shared with us has to do with the Christian tradition, the Jewish tradition, the Muslim tradition, the Hindu tradition, and the Buddhist tradition. And I will send John a page that has these links that are active. And you can download all of these resources. So we're at the cusp in pastoral counseling of, I think, reaching to what the founding mothers and fathers were thinking about. How do we integrate the resources of faith traditions and religion and spiritual variables as an asset to one's counseling? Let me talk about my perspective related to the future. Same picture, different perspective. I'm envisioning a future where spiritual care providers, that's faith leaders, that's chaplains, that's pastoral counselors, that's spiritual directors, that's educators, and so forth, see themselves and each other as partners in a spiritual continuum of care which traverses on a two-way path from community to healthcare facility and care facility to community. In conversations with colleagues in chaplaincy, I've asked them, and something I think we're going to be working on, what happens to the spiritual thread of care when a person is discharged from a facility into the community? If spiritual care makes sense for a client or a patient while they are in a hospital or a psychiatric facility, why wouldn't that be part of discharge planning? It's something that hopefully we can talk about and think about as a model of care. The context of care, the skill sets, and the pastoral clinical responses are complementary. They're all focused to the same point, maybe utilizing different ways to get there, but it has to do with health of individuals, families, and communities. And together, I think, this cadre of spiritual care providers on a journey together can facilitate qualitative differences, improvement of well-being of the recipients of the care, and also improvement of the health status of communities. It also has the potential of a quantitative difference. I think money will be saved, and hopefully cost savings can be shared. So this is a model in my mind that also has a business plan behind it. It's not enough to envision the future, we must all co-create it. So how do pastoral counselors, this is an important thing to me as we think about this future, how do pastoral counselors and colleagues facilitate access to care for all and come to grips with the economic and political realities which so often underlie the distress which individuals and families experience? This is a justice issue. As a result, I began to consider, along with colleagues, not only inquiring about what's going on in one's private world, somatically, emotionally, spiritual concerns, but also what is transpiring in the broader community where one works and lives. As we know, the best indicator of one's health status is one's zip code. Where you live has everything to do with how well you are or how sick you are. I have often thought that clients access counseling services, whatever kind, when their expectations of the world no longer fit their experience of the world. Thus, one's values, the underpinnings of meaning, need to be reevaluated. And similar experiences are taking place in the caregiving world as well. Models of service and treatment are going through a similar process of rapid change. Not only here, it's in the UK and it's in other places as well. We now embrace models of treatment and care that move beyond individual care and episodic treatment to population health and a public health approach to care. The health care field is complementing treatment with models of prevention, promotion, and recovery. And so we now speak of systems of care punctuated by integrated and complementary care. And I'm getting to a point to talk about the significant role that faith communities play in this. So finally, what about the community? As we had three perspectives about pastoral counseling, I also want us to think about other partners in community that also have ways of thinking internally. Because as I think about this model of integrated care, it's a way of traversing boundaries within an organization, within a profession, and then how do those organizations and professions begin to mesh across the boundaries into the community. So just take a look at this as an example of, if we're going to be talking about healthcare, we're talking about integrating and working with healthcare organizations. They have a three-world view as well, just as those Escher pictures explicated as I talked about pastoral counseling. Within healthcare organizations, there's the clinical, there's the operational, there's the financial. And these are the questions that are asked in those domains. The clinical says, what care is called for? Is it high quality? The operational people say, what will it take to accomplish this? Is it well executed? The financial people say, how will care utilize resources? Is it of good value? So we need to realize that many of healthcare providers, organizations, and systems are trying to think about the same thing. So it's not enough to do it just internally within one organization or one profession, but we need to begin cross-pollinating ourselves with other professions who are thinking about the same thing. So how do we begin to think about this way of integration in community? We have a picture of this health system, of this three world view, which sits in the context of community. Increasingly, healthcare organizations are going to finally have to take health communities seriously. Because when you think about hospitals used to get paid when people were readmitted, it's not going to happen anymore. So where do you go in communities to develop sustainable resources to help people maintain health and wellness? One place that I think is a significant partner in this are our faith communities. So we have a community where there is a health public policy that speaks to the health system about how can you now work with us in a different way, and how do we create those supportive environments in community to keep people well or to prevent disease and promote health, or to help people recover from substance use and mental health and mental illness issues. And how do we strengthen the community to take charge of healing their own in a way that works for them? So at the bottom, near the bottom of the slide, you begin to get a sense of an activated community. And what's really important is an informed, activated patient. How do we help people care for themselves and not think that they always have to have someone else care for them? And on the other side, with the health system, how do we develop proactive practice teams and especially prepared, proactive community partners? I'm sure in all the communities where you are, hospitals are working diligently to figure out who in their communities they can work with for support of people. This is something we all embrace. This is another, we had the pastoral counseling side of its domain, we have the health system, healthcare organization with its three world view. Now we talk about the biological, the psychological, the social, and the spiritual. That is what health is. And I go back that 50% of these four quadrants, the social and spiritual, I think primarily, again, can land in equipped and creative faith communities. And I'll get to examples of how we will equip faith communities to do this. So what is it that helps all of this live and move and be? What's really important for me as we talk about the change of systems, that that we don't forget the individual in the midst of this at all. Think about this individual, who am I, at the center of this slide. And what I want to do is to highlight that care is broader than treatment. So when we talk about pastoral care, when we talk about spiritual care, that is the work of many of you in this room who are faith leaders. And as I thought about this slide several days ago, when you look at the center of who am I being and becoming, I was wondering, when you went to see your doctor or a clinician to have therapy, we usually get an intake form. We usually get a series of questions to write and to respond to. And I was wondering on a intake form if there was the question, who am I becoming? Or a question, what makes me tick? Or a question, where are my sources of inspiration? I think that conversation with your counselor or your physician would take on a different flavor than, importantly, how are you sleeping and all of this. But to get to the questions that begin to, I think, invigorate that spiritual part of us. And so the individual and community is surrounded by all of these things. Social aspects, family, religion, faith, aspirations, all of this are part and parcel of the people with whom and for whom we care. This is time for a little response. What do you see when you first saw this? And what did you see? It's two pictures. And so this gets back to how we look at something. At first glance or at second glance. It's not always what it seems to be. What guides for you, all of you, what guides your perspective? I have new glasses, so you might wonder what I'm doing up here. Because my perspective needed to be tweaked. But when your perspective has changed in your own personal and professional life, what did you see differently? And not only what did you see differently, but what did you do differently? Let me tell you my experience when I realized I did this without knowing. I was at a conference in Washington around health, and it was a 2-day conference, and so the second day began with a breakfast. And I was standing in line, person behind me, she was a psychologist, and so kind of chatting as you go from the bagels to the cereal. And so she said to me, "What do you do?" And without thinking, I said, "I'm an evangelist for health." And she hadn't eaten anything yet, so she didn't choke or anything. So we were walking in the line, and she said, "Well, what's that?" I said, "I believe in health. I'm also a Presbyterian minister, so that probably is where the evangelist comes." Presbyterians wouldn't say that very often, though. But I believe in health. I believe in good health. So she said, "Can we sit down and talk some more?" And as we were talking, I asked her some questions, and she said, "Why do you do this work?" And without thinking, I said, "Because people die." And I think it behooves us to be able to succinctly state who we are and why we do this. And we both talked, and she said, "I think I might be an evangelist for health too." But we talked about how we often describe ourselves with these titles and all this work. But what it's really about is enhancing health and saving lives. I want to spend a little bit of time over these next couple slides because I want to tell you what has changed my perspective about how I think about health and illness and how I think we've helped the American Association of Pastoral Counselors, thinking about care. So I want to highlight two research protocols which substantiate my rethinking of this. The first relates to the precipitants of chronic illness and early death, and the second highlights the assets that facilitate life and resiliency and decrease at-risk behavior of youth. How many of you have heard of the Adverse Childhood Experiences study? This study was done about 8 to 10 years ago, and you just Google it, Adverse Childhood Experiences study. But I believe that these studies point us to models of care that are more focused on disease prevention and health promotion, and specifically invite faith community partners as an asset for overall health. If you're going to remember two things, this is the first thing I'd like you to remember of what I've come to realize. I posit that the precipitants of illness and health and well-being have as much to do with positive and healthy relationships as it does with one's genetic predisposition. A study by the Kaiser Permanente insurance company in San Diego County, California. So this was a study of basically middle-class people because they had health insurance. So when you add poverty to this, the outcomes would probably even be exacerbated. The researchers discovered something totally unexpected after evaluating their study of 17,000 participants. They identified the clustering of psychosocial life experiences in relation to chronic illness. So they looked at what are the precipitants of heart disease, cancer, diabetes, and so forth. And along with that, they saw the clustering of these psychosocial life experiences that they called adverse childhood experiences. And adverse childhood experiences are experiences experienced in the household prior to the age of 18. And it increases the possibility of developing a chronic illness and resultant early death. And these are the 9, quote, ACEs. Recurrent physical abuse, recurrent emotional abuse, contact sexual abuse, an alcohol or drug abuser in the household, an incarcerated household member, someone who was chronically depressed, mentally ill, institutionalized, or suicidal, a mother, female caretaker treated violently, one or no parents, emotional and physical neglect. Consider the layering of this pyramid. You have the foundation of adverse childhood experiences, which move to social, emotional, and cognitive impairment, moving to adoption of health risk behaviors, moving to disease and disability and social problems, and 25% early death. The grading of the adverse childhood experiences is 1 point for the experiencing of these, not a number of incidences, but just experiencing these in one's lifetime. The second piece of research, the developmental assets, discovering what kids need to succeed, the Search Institute in Minneapolis. This protocol identifies 40 research-based positive qualities that influence young people's development, helping them become caring, responsible, productive adults. And it's based in youth development, resilience, and prevention research. This has both these protocols have research behind it. And the framework has been adapted to be developmentally relevant from early childhood through adolescence, and it's also being tested and utilized worldwide. So it's applicable across cultures. And the research shows that youth with the most assets are least likely to engage in 4 different patterns of high-risk behavior: alcohol use, violence, illicit drug use, and sexual activity. In short, the more assets a young person has, the more likely he or she has a chance to succeed in life. So do our facilities Do our hospitals, do our counseling centers, do our practices, do our educational programs recognize these research protocols and include them in the training of future professionals so they can be used in communities? AAPC, I'm proud to say, has taken this seriously, and I want to highlight a few initiatives that we are involved in. This first slide is Mental Health Ministries, which is a wonderful website with resources across the multiplicity of faith communities to increase the capacity of faith communities to respond to mental health issues. Mental Health Ministries, along with Pathways to Promise in St. Louis, we've embarked on 3 pilot projects to increase the capacity of faith communities to address the issue of serious mental illness and mental health in the community, but also to support people in congregations. There's a pilot project in St. Louis. There's a county project in DuPage County, Illinois, the Interfaith Behavioral Health Network of DuPage County. And there's a pilot project in the state of Washington between the State Association of Faith Communities and the State Department of Behavioral Health. And that is partially funded by federal mental health transformation money. Another project that AAPC has been involved in, this is a 9-year project, is with the National Association of Children of Alcoholics. You see on the side there on the tab Clergy, if you go to this website, click on the Clergy tab, there's a multiplicity of resources that you can download. It's a great website. And this is where we come to talking about partners. The Commonwealth of Pennsylvania has paid me and another colleague, we just finished this, they paid us to do 14 trainings through the Bureau of Drug and Alcohol programs. 14 trainings in 14 locales across the Commonwealth of Pennsylvania. Bringing together faith leaders, bringing together community providers, bringing together recovery programs and faith communities to increase the capacity of congregations to care. 1 out of 5 children who shows up in services every weekend is impacted by substance use. 98% of faith leaders say this is an important issue in my faith community, but only 12.5% of faith leaders have had ever any training related to this. So this is a marvelous resource. We did a training, it might sound an oxymoron, we did it in Las Vegas. We had over 400 faith leaders show up for this. And it was sponsored by the Department of the Mayor. I just turned off my computer, which is not good. But it will reboot. The next slide, technical assistance as I talk. Here we are. Here we are. There we are. LA County Department of Mental Health this year will be hosting its 26th annual conference on spirituality and mental health. And if you want to talk about a diverse audience, ethnically, across faith communities, last year it was held in a Buddhist temple. LA County Department of Mental Health is implementing what they're calling the Clergy Academy, where they want to build direct relationships with faith communities in community with their outpatient treatment programs and their programs for recovery. The next slide is a project that AAPC is going to be participating with in conjunction with the American Psychiatric Association. And there'll be bringing together faith leaders and psychiatrists. And these are several of the things that this initiative is going to attempt to do. One, to establish ongoing dialogue between psychiatrists and clergy. Create resources, new resources to train religious leaders about mental health, building on what is already there. Create new resources that are useful to psychiatrists about faith in faith communities, especially as it might pertain to mental health recovery. Improve mental health education offered in seminaries and in continuing education. And explore ways for medical school and psychiatric residency training programs can increase their capacity to address the importance of faith and spirituality in their clients and patients in their communities. So it's not only us talking about me talking about the importance of faith communities, but we have the Department of Mental Health in LA County. We have the Bureau of Drug and Alcohol Programs in Pennsylvania. We have the Mayor of Las Vegas, and now the American Psychiatric Association. Those are significant and important partners. In the video, in the convocation memo here, it talks about the Coordinated Care Network. And what I want to do almost before I end is play a short video. And this is where I learned so much from my colleagues in Pittsburgh, from my faith community partners, about what can happen in a community where there was no healthcare safety net, that we build it. And part of this healthcare, the Coordinated Care Network, were 38 congregations who were significant partners in the city of Pittsburgh that came together with 16 nonprofit organizations and 7 federally qualified health centers to say, we need to build a safety net in Pittsburgh.
Pittsburgh, I believe, is a unique community in many ways. Many people know it as the city of bridges, and what we feel we are doing in these faith health initiatives is building bridges across disciplines, across communities, and across faith groups to address the well-being of communities.
One of the interesting things about Pittsburgh, our topography really defines us in terms of who we are. We're a valley community with hills all around it. Unfortunately, a lot of the at-risk communities, public housing, for example, in this city is built on some of the most inaccessible hilltops and mountaintops around. While we have no shortage of availability of healthcare services, the issue of 100% accessibility is a challenge for us.
An agency such as the Community Care Network in Pittsburgh has been able to get through their religious ties into church populations and have used those people who are part of the faith-based community to go out into the broader community in which they live, to get people to come in and to get them appropriately screened and educated, because really the goal of public health is education.
What's unique about the Coordinated Care Network is that a series of spiritually based organizations together with community-based organizations as well as federally qualified health centers came together not just in an informal way, but were willing to clinically coordinate their programs, make them managed care friendly, and then offer them back to the insurance community as well as to medical assistance and Medicare as a way of reaching the most vulnerable people in our population and bringing them into the mainstream of care. We've been able to show that through a coordinated system of care, we can decrease utilization of hospital days as well as utilization of the ER, which a lot of people use as kind of their primary care center, which in the end will help to save managed care companies dollars.
We took traditional public health where we had been a top-down agency and said, this is what you should do, and involved the community, and gave them approximately $5 million a year and said, here is the budget that we have to deal with. You help develop a plan that will address the issues in your various constituencies and communities.
The Coordinated Care Network has 180 psychosocial spiritual intervention programs that are offered out of 60 sites throughout the city of Pittsburgh.
We believe that faith-based organizations have a special commitment to the community, to people, to a more integrated approach to care.
Our original idea was that we would deliver services to people out in the community, and what we came to understand is that they wanted skills. They wanted to know how they could care for themselves. By training people with some technical information, how you eat, when and how you exercise, smoking cessation techniques, whether or not you take your medications, whether or not you get appropriate tests and monitoring. They were able to use the church basis, its way of helping its congregants, and they're able to use those techniques they already knew to develop very effective programs.
A holistic model of healthcare combines or integrates physical health with mental health, with social health, with spiritual health.
Working through a faith-based organization reaches people that may not be connected in any other way to healthcare. They may only trust their church to help them.
Parish nursing is a partnership between a hospital and a faith-based community. And what's wonderful, I think, is not only do I serve the people in the church where I practice, but I also serve the people in the surrounding community.
For issues like this, we have to reach at the highest level. And 100% accessibility, I think, is something we have to keep in front of us, and we move towards it. That's the kind of people we are. We're called to that very high standard, and I wouldn't accept anything less.
Do I dare touch this? You know, I have one other slide, but it disappeared. Remember the opening slide of those kids with the world? The closing slide was another kind of kids drawing of the world, and on it was, "Oh, the places you will go." Now, I know Dr. Seuss is not a faculty member of the Graduate Theological Foundation, but all of us are going to leave here tonight. We're going to go back to our respective homes, the hotel. People might be, you'll be traveling back to the UK. Others of you will be traveling abroad. And so as all of you who are, when you leave, I want you to think about, oh, the places we will go. And also think about the people who are already there. Think about the people who are much like you, who want to do well, do right, in their sense of calling whatever tradition they might have, to enhance the well-being of their communities and their families and of their children and of their faith groups. It seems to me that we who provide care cannot accept any less of a call to go to those many places from which we came. So if I don't have a chance to talk to you during the break or as you have to leave to go to wherever you go, I ask you to take that with you to think about, oh, the places we will go, and oh, the people whom we will meet, and people who will meet us as partners in what I think is a very creative, and at least in my professional life, I think the most opportune time to do what all of us think we want to do. Because what I have found is that there are people of influence who go to services every weekend. And they are looking for, respond to their own sense of their faith tradition. So I want to thank you for, John, for inviting me, and for all the staff and faculty of the Graduate Theological Foundation. I apologize for a few of the technological difficulties, but I'm most grateful for all the work that all of you do. Thank you.
Okay, for 5 minutes I'm going to pull this up a bit near my shoulder height. Thank you for what you've given. I was thinking very much, as someone who comes from a medical family, I'm not a medic, but as I said to my brothers, I often deal with your mistakes. Part of this is because we belong together. I think care is about a vocation, it's about being human. And one of the things that I think we're reaching out through what you've been sharing with us is the importance of recognizing all the things that make us human and fit together, and how our journey is not just a journey to places, but it's in time. You and I are on one stage of a journey, there are many here on another. But when you go to different countries, different places, I always think, as you've suggested and hinted, people are very much the same. Our needs are the same, and the GTF brings all those people together. So I hope that what you've said to us will bear fruit in many things. So can I thank you on our behalf for your presentation, your lecture, and your gift. So yet again, thank you. We have 5 minutes, and then you can enjoy Doug outside. But if there are any pressing questions, we've got 5 minutes, so maybe 1 or 2 people would like to field a question. If you want to, stand up and catch my attention and then shout it out. They may be just stymied.
Maybe we're ready to go outside and play.
Maybe. But I've just got a question to ask, sure, so we can all go out, and that is, how do you yourself see the great development in terms of spirituality, religion, affecting medicine? I mean, there's a concomitance there, and I really feel that in the UK, for a start, we lost a lot of the spiritual-based beginnings of Medicare and care, because many of our hospitals began as spiritual institutions, and they went. How do you somehow recapture that?
Some of you might know the name Gary Gunderson, whose name was on 2 of those slides. Gary, this is an example, I'm getting to that. Gary is vice president at Baptist Health System at Wake Forest Medical Center in Winston-Salem, North Carolina. Before that, he was in Memphis, vice president of a hospital, and before that, he was at the Interfaith Health Program at the Carter Center. What Gary is doing, he is working with a White House initiative, and this is a sign of hope. He's working with a White House initiative of 32 health systems. And these health systems were initially founded by faith communities, the Deaconess Hospital, the Methodist Hospital, the Presbyterian hospitals, and so forth. And he has 32 of them that he's working with because the administrators of those hospitals are interested in reconnecting to their founding roots. So if we have something coming out of the White House initiative of 32 health systems that are saying, you know, maybe we have strayed from the founding parameters of what we were called to be, and they are looking and working back towards that. That is on a larger scale. But in my job, I travel just enough. But invariably, whenever I travel, I meet people who inspire me. People who I have never been introduced to, but people feel like I know. I had some of these conversations at the tea today. Exactly. So for me, that to me is the sign of hope that I think there are a lot of people in various levels of influence who get this, but they also feel isolated.
Yeah.
So.
Yeah, and I think that's, I mean, what you said, collaboration seems to be key. But I think also the great gift we've got is kind of care too. Oh, there's one question over there.
Unfortunately, we live in an era when many people deny basic scientific facts, saying that they are only theories, or even less than that. We know what we're talking about. What we're talking about here is good medicine and good science. How do you deal with those people who reject this kind of scientific thought and feel that faith is the only approach and that medical approach is not valid at all?
Pray for them. I engage people. I engage those, and I meet different conferences, and we have these conferences related to substance use, and people say, oh, if they were prayed harder, What I have found, and this is why it's good to do these conferences in a group with other couple hundred faith leaders, because one of the things that we end up talking about is, what's your tradition tell you about this? And so what I have found in working in these presentations with the groups of faith leaders end up engaging other faith leaders. The other thing that I really used to avoid, but really enjoy and take seriously, is to enter into a theological conversation with that person to understand what is grounding that perspective. Before I would maybe avoid them. But I really, when I do these trainings, I really look forward to someone who will say, well, what about prayer? This person is sinful. And what I learned is that that is often around substance use. And then we end up talking about what happens when sin separates us from others, from the other. And so if we talk about, so I really try to engage as much as possible in a how can I say this? In a respectful conversation.
You feel you've succeeded?
What I have found is the other faith leaders who come to these trainings, they succeed. Because they engage their colleague. It's not me as the presenter. So I spend time talking to people like that.
There.
Thank you for the wonderful presentation. Is there any initiative about the future in treating the mental illness? For example, here in America and a couple other places, we don't force people to accept treatment. Is there any initiative, future initiative, in balancing the way we treat mental illness in the area of refusal of treatment? And how do you balance it?
Balancing patient rights and all of that. It's a difficult balance. I think there is a new bill in the Congress that Representative Murphy, who is from Pittsburgh, is trying to introduce around that. A good friend of mine who is at the opposite spectrum, theologically and politically, working with him, he's a psychiatrist. It's difficult. How do you balance the rights of people and communities and the rights of individuals? I think that, so I'm not really answering your question because I don't have a perfect answer, because there are ethical and legal issues, that fine line that are difficult to answer. I think the best thing to do is this idea of early awareness. There was a shooting in Pittsburgh, some of you know, in a school, and in that young man's locker was a note that he wrote 5 days earlier. If that note had been found, that young man would have been hospitalized for treatment, but it just didn't happen. So I'm sorry I don't have a good answer to your important question.
One. We've used you as the last one.
Yes, thank you again also for your wonderful presentation. I was noticing when the nurse was talking, who said that she was being able to give nursing care to the people in her parish, plus others as well. And one of the areas that I'm very interested in is in disaster mental health, looking at how we help people in natural disasters, community terrorism, and the churches and the church communities. The more they can get aware of some of the ways they can help, the Red Cross, other organizations working as a team, the better they're able to serve the community. And that's another form of mental health. So I just wondered if in the work you're doing, if you're looking at how to educate parish members of parish communities, priests, ministers, rabbis, and so on, and how they can be helpful in those situations, because it's unfortunately more and more of a problem, especially in the United States, but all over the world.
Well, one initiative that is being and will be increasingly implemented in faith community is mental health first aid. That came from Australia, and the National Council for Behavioral Health in Washington has a specific training module for faith leaders. And in these initiatives I talk about, especially around the mental health issues, not only thinking about what you do after something happens, but what are the warning signs? Loss of appetite, not sleeping, a person being violent, acting differently. And I think we are uneasy in faith communities kind of raising that, because we sometimes err too much in a situation of not getting someone to care, or saying, well, maybe Pastor so-and-so or Rabbi so-and-so or Imam so-and-so, maybe you should talk to him. So yes, all of this relates to better equipping faith leaders to not only support people who are going through this, but also how to get people to levels of care. There is a unique initiative in northern Pennsylvania, the 13-tier states, and it's called the Behavioral Health BHARP. It's the Behavioral Health Association of Rural Pennsylvania. 14 states across the state of Pennsylvania, very rural. It involves behavioral health providers, primary care physicians, and faith leaders, because they realize they're treating 90% of the same people and don't know it. And what happens if we all work together? And so that becomes a way of the faith leader knows the behavioral health provider, so let me call so-and-so and get you an appointment. And it's all about building these kinds of relationships that facilitate that.
Yeah, I think I'm going to encourage us to continue a conversation with you outside, but don't forget to make sure that we can get hold of your slides.
And I'll make sure to turn off my microphone too.
Yeah, but thank you once again for everything.